Good afternoon, everyone, and welcome to today's Public Health Ontario's Rounds presentation titled Updates on Influenza, COVID-19 and RSV for the 2023-2024 season. My name is Andrea Saunders. I am a communicable diseases specialist at Public Health Ontario, and I have the distinct pleasure of moderating today's session. Before we get started, I have a few housekeeping items to mention. We have disabled the chat pod to limit any distractions during the presentation. However, there will be a discussion period immediately following the presentation. So if you do have questions you would like to ask, please go ahead and enter them in the Q&A pod at the bottom of your screen at any time during the presentation. If at any point during the session you experience technical issues, or if you require CME credits, please email capacitybuilding@oahp.ca. And as moderator of today's session, I would like to state that I have no conflicts of interest to disclose. It is now my pleasure to introduce the speakers for today's presentation, Michael Whalen, Dr. Richard Mather, and Dr. Mon Hasso. Michael Whalen is an epidemiologist lead on the communicable diseases team in health protection at Public Health Ontario. His portfolio includes influenza and emerging respiratory viruses, tuberculosis, legionellosis, and invasive group A streptococcal disease. Mike completed his Master of Science in Epidemiology at Queen's University. Dr. Richard Mather is a public health physician in health protection at Public Health Ontario. He is an assistant professor at Queen's University in the Department of Family Medicine and has a Master of Science in the Control of Infectious Diseases from the London School of Hygiene and Tropical Medicine. Dr. Mon Hasso is a medical microbiologist at Public Health Ontario, and he leads the viral detection and molecular diagnostics portfolio. He completed his medical degree as well as his master's degree in medical microbiology from Baghdad University in Iraq. In 2020, he graduated from the medical microbiology residency and fellowship program in the Department of Laboratory and Pathobiology at the University of Toronto, and completed his certificate in medical microbiology from the Royal College of Physicians and Surgeons of Canada. And with that, I will now pass things over to Michael to begin the presentation.
Thanks, Andrea, and welcome everyone. Thank you for joining the Rounds update on influenza, COVID-19, and RSV for the 2023-24 season. Just to start off, none of the presenters have any conflicts of interest to disclose. So the learning objectives of this session are that by the end of the session, participants will be able to summarize current epidemiological trends in influenza, COVID-19, and respiratory syncytial virus, or RSV, activity in Ontario, Canada, and internationally, to list the vaccine products available in Ontario for influenza, COVID-19, and RSV for the 2023-24 season, describe the use and benefits of antiviral medications for the treatment and prevention of influenza, and describe the testing options available in Ontario for influenza, COVID-19, and RSV for the 2023-24 season. So we'll start off with an overview of flu, COVID-19, and RSV activity in Ontario, Canada, and internationally. And then I'll pass it over to Dr. Mather for influenza, COVID-19, and RSV vaccine updates for 2023-24, as well as information on antiviral medications for influenza and COVID-19. And Dr. Hasso will cover COVID-19 and seasonal respiratory virus testing for the 2023-24 season. So moving on to respiratory virus activity in Ontario and Canada for the 2022-23 surveillance period, the season that just passed. It was different than previous seasons, and it was the first winter since the pandemic without any broad public health measures in place, such as masking or physical distancing. There was a lack of seasonal respiratory virus activity since the pandemic began, meaning the population may have had reduced immunity to seasonal influenza, RSV, and other respiratory viruses. So influenza A activity did start and peak early in the 2022-23 season. It started increasing in October before crossing the 5% threshold, which is considered the start of the flu season by Public Health Ontario and Public Health Agency of Canada, before peaking at the end of November. and then declining through December into January. The influenza A season was characterized by H3N2 dominance in terms of the cases where we had subtyping available. Close to 95% of them were H3N2. Influenza B did circulate in the 2022-23 surveillance period during a more typical time period for flu B in the spring. So activity took place from March to June. However, it was low for most of that time period. So moving on to COVID-19 activity in Ontario, we're looking at the two graphs on the left, the COVID-19 activity signal through wastewater, and on the right, the percent positivity for COVID-19 tests. You can see peaks in October in both the COVID-19 wastewater signal and the percent positivity, as well as in December. Before a generalized decline took place through to the end of June. And we've had increasing COVID-19 activity in Ontario through July until present. And COVID-19 trends were similar across indicators in the 2022-23 surveillance period. So with activity peaking in October and late December or early January for percent positivity, wastewater outbreaks, cases, hospital bed occupancy, as well as deaths. And the general decline in activity was seen in these indicators until June 2023, and COVID-19 activity has been increasing through the summer. So in terms of RSV activity, RSV activity increased in October of the 2022-23 surveillance period and had sustained activity through to January. This was earlier than pre-pandemic seasons in terms of RSV activity in the province. So the trends in percent positivity of respiratory viruses in Canada in the 2022-23 season were similar to those in Ontario. Influenza A test percent positivity increased through October and peaked at the end of November. H3N2 was the dominant influenza A subtype nationally, and COVID-19 activity had peaks in October and late December and early January, followed by a decline until July based on test percent positivity. And likewise, RSV test percent positivity increased in October with sustained activity through January before declining. So what did things look like internationally in 2022-23 season? So the influenza season in Australia appears to be similar to 2019 in terms of timing. The graph on the left, you'll see the number of notifications in red for influenza in the 2023 season, and you can see that it is similar to the light green line for 2019. In addition, it seems to have been a little bit less in terms of size compared to the 2022 season. The right-hand graph, you'll see the proportion of tests that were positive for influenza. And you can see that influenza B and influenza A were co-circulating in this past season. And among the influenza A tests where subtyping was available, H1N1 was the dominant subtype being identified. And this was similar in many other countries in the Southern Hemisphere, with the exception of South Africa. So in terms of COVID-19 internationally, in the United States and in England, increases in COVID-19 activity were being observed through the summer. The left-hand graph is for the United States, and the orange line is the weekly percent positivity. So you can see that increasing through June and July through August. And on the right-hand graph, That's the blue line is the percent positivity for England, and you can see that increasing from July through August. And other countries have also experienced increases in COVID-19 across the summer, including many others in the European Union. In terms of RSV activity in Australia, to get an idea of potentially what may happen here, did increase in peak earlier than last year and has been declining since June. It should be noted as well that the CDC issued an alert to indicate increasing RSV activity in the southeastern part of the United States in September, particularly in Florida, with a note saying that oftentimes activity begins there before spreading north. So overall, the 2022-23 period was unusual in Ontario compared to pre-pandemic seasons. It was characterized by heightened influenza and RSV activity in November and December, and in Ontario and also nationally. A good news point was that the influenza vaccine effectiveness in Canada last year was 54% against influenza A, H3N2, which is higher than it often is. In the first fall and winter, without any public health restrictions, COVID-19 activity was elevated until the late spring of 2023, with peaks in activity in October and December. The gradual decline in activity from January to June stopped and began increasing through July, and activity has continued to increase since then. So what might we see in the 2023-24 surveillance period in Ontario? So similar to pre-pandemic seasons, circulation of influenza and RSV in the community is expected. Currently, influenza and RSV activity is low. However, there is a trend that you can see in percent positivity for RSV of slightly increasing percent positivity from the end of August until present. However, activity is still low. And then based on Southern Hemisphere activity, it's possible influenza and RSV activity could start early. And the influenza A, H1 may be the dominant subtype this season. And oftentimes, following an H3N2 dominant year, influenza A, H1 will end up being the dominant influenza A subtype. So we'll see. But in the early data, 60% of the cases that have been reported to us through IFAS with subtyping available have been H1N1. COVID-19 activity is already increasing based on trends starting at the end of the 2022-23 surveillance period. And it's possible that potentially immunity gain during the 2022-23 flu, RSV, and COVID-19 peaks may have waned. And last season did really emphasize the importance of immunization. And before I turn it over to Dr. Mather, I just wanted to put in a plug for Public Health Ontario's new interactive Ontario respiratory virus tool. This tool is updated weekly on Fridays at 11:30 and provides data on influenza, COVID-19, RSV, as well as other respiratory viruses, and you can access it online on Public Health Ontario's website. So Dr. Mather, over to you.
Thanks, Mike. I'm happy to be able to talk today about vaccines that are available for influenza, COVID-19, and RSV for the upcoming respiratory virus season. I'll be going over the available vaccines and scientific rationale for their use, but an in-depth discussion of ministry guidance is out of scope for this presentation. This table shows the components of the Northern Hemisphere egg-based influenza vaccine for this season, 2023-24, in comparison to the previous season, 2022-23. The strains recommended by the World Health Organization for inclusion in the Northern Hemisphere vaccine are based on strains that were circulating when the recommendations were made in February of this year. This year's vaccine has one change compared to last year, with a different influenza A H1N1 component recommended this year. The other three strains are unchanged from last year's vaccine. Quadrivalent vaccines contain all four of the strains shown here, and trivalent vaccines will contain two influenza A strains, one for H1N1 and one for H3N2, as well as a strain from the B. Victoria lineage, but they do not contain a strain from the B. Yamagata lineage. These are the vaccines that are available as part of Ontario Ministry of Health's Universal Influenza Immunization Program, or UIIP, for the 2023-24 influenza season. They're all egg-based vaccines. There is a standard dose quadrivalent vaccine available for all age groups 6 months of age and over. And for those 65 years of age and over, in addition to the standard dose quadrivalent vaccine, there's also a high dose quadrivalent vaccine and an adjuvanted trivalent vaccine available. This table shows characteristics of the UIIP vaccines that are available for adults 65 years of age and older. The high-dose quadrivalent vaccine, QIV-HD, and the adjuvanted trivalent vaccine, TIV-ADJ, are the vaccines that are only available for adults 65 years of age and older. And the standard dose quadrivalent vaccine, QIV, is the one that is available for all age groups. High-dose quadrivalent vaccine has 4 times the amount of antigen for each strain it contains compared to the standard dose vaccine. And studies have shown that the higher antigen content of a high-dose vaccine improves the immune response and prevention of influenza hospitalizations compared to standard dose vaccine, which is important since older individuals may not respond as well to influenza vaccines compared to younger individuals. The high-dose vaccine has higher rates of local and systemic reactions, which are generally mild and transient. The trivalent adjuvanted vaccine, the adjuvant is added to enhance the immune response to the vaccine, but there is insufficient comparative evidence to an unadjuvanted trivalent vaccine to draw a conclusion about the effectiveness of the adjuvanted vaccine. The National Advisory Committee on Immunization, or NACI, provides the following recommendations on choice of influenza vaccine for individuals 65 years of age and older. For individual level decision-making, NACI advises that when available, the high-dose quadrivalent vaccine should be used over a standard dose quadrivalent vaccine, given the burden of influenza A, H3N2 disease, and the good evidence of a high-dose trivalent vaccine providing better protection compared to a standard dose trivalent vaccine in adults 65 years of age and older. And other than a recommendation for using the high-dose quadrivalent vaccine over the standard dose vaccine, NACI has not made comparative individual level recommendations on the use of the other available vaccines in this age group. In the absence of a specific product, any of the available age-appropriate influenza vaccines should be used. For public health program level decision-making, NACI advises that any of the available influenza vaccines authorized in this age group should be used. And there is insufficient evidence on the incremental value of different influenza vaccines, such as cost-effectiveness assessments, to make comparative public health program level recommendations on the use of the available vaccines. For COVID-19, Health Canada recently authorized 2 updated monovalent mRNA vaccines targeting the COVID-19 Omicron XBB 1.5 subvariant. The vaccine from Moderna was authorized on September 12th, and on September 28th, the vaccine from Pfizer-BioNTech was authorized. These 2 vaccines are authorized for use in individuals who are 6 months of age and older, and authorized for both those who are previously vaccinated as a booster dose and those who are not previously vaccinated, also known as a primary series. There is one other monovalent XBB 1.5 COVID-19 vaccine that is currently under review by Health Canada from Novavax, and it's anticipated it will be available at some point in the fall, but timelines are not currently available. On the same day as the Moderna monovalent XBB 1.5 vaccine received Health Canada authorization, NACI released an addendum to their guidance on the use of COVID-19 vaccines in the fall of 2023. NACI recommends that for those previously vaccinated against COVID-19, dose of an XBB 1.5 containing formulation of COVID-19 vaccine is recommended. It has been at least 6 months for the previous COVID-19 vaccine or known SARS-CoV-2 infection. NACI guidance also noted that booster vaccination using shorter intervals between 3 and 6 months following previous vaccination or infection has not been shown to pose a safety risk, though evidence shows that the antibody response is higher with longer intervals. NACI also emphasized that immunization is particularly important for those at increased risk of COVID-19 infection or severe disease, which includes adults 65 years of age or older, residents of long-term care homes and other congregate living settings, individuals with underlying medical conditions, individuals who are pregnant, individuals in or from First Nations, Métis, and Inuit communities, members of racialized and other equity-deserving communities, and people who provide essential community services. The monovalent XBB 1.5 vaccines from Moderna and Pfizer-BioNTech are the first vaccines based on an XBB subvariant that are authorized for use in Canada. These vaccines are the first COVID-19 vaccines to receive Health Canada authorization for use in previously vaccinated individuals less than 5 years of age as a booster dose. In unvaccinated individuals less than 5 years of age, 2 doses of the Moderna vaccine or 3 doses of the Pfizer-BioNTech vaccine is recommended. In unvaccinated individuals 5 years of age and older, a single dose of either vaccine is recommended. For previously vaccinated individuals, a single dose of either the Moderna or Pfizer-BioNTech XBB 1.5 vaccine is recommended for all age groups. And previously vaccinated refers to a completed 2 or 3 dose series for those 6 months to 4 years of age. And for those 5 years of age and older, previously vaccinated refers to the receipt of at least 1 prior COVID-19 vaccine dose. And further NACI guidance on XBB vaccine use in unvaccinated individuals is anticipated to be released shortly. For RSV, on August 4th of this year, Health Canada authorized the first RSV vaccine for use in Canada. It was authorized for the prevention of lower respiratory tract disease caused by RSV in adults 60 years of age and older. This fall, Ontario will offer publicly funded RSV vaccine to those 60 years of age and older living in long-term care homes, elder care lodges, and some retirement home residents. The Ontario Immunization Advisory Committee has recommended against routine co-administration of RSV vaccine with influenza and COVID-19 vaccines on a precautionary basis. The complete OIAC statement was posted last week on the Public Health Ontario website and outlines the considerations where co-administration may be considered, including when there's a risk that the individual otherwise will not receive the recommended vaccine doses. NACI is reviewing the use of RSV vaccines and will provide recommendations and an update to the Canadian Immunization Guide in the future. It is important for individuals to receive all vaccines they're eligible for to protect against influenza, COVID-19, and RSV, as vaccination is the most effective way to reduce the risk of severe outcomes and complications from these pathogens, including hospitalization and death. Another potential benefit of receiving influenza vaccine is that individuals with recent viral illnesses, such as influenza, may have a higher risk of contracting other infections, such as invasive group-based streptococcal disease. So reducing your risk of influenza infection through vaccination may reduce your risk of other infections. To support vaccination this respiratory season, co-administration of influenza and COVID-19 vaccines can present an opportunity to provide individuals with these vaccines in a more timely way. As I noticed on the previous slide, the OIAC has recommended against routine co-administration of RSV vaccine with either of these products, but there are some situations where all 3 vaccines may be offered together. It is anticipated that there will be co-circulation of influenza, COVID-19, RSV, and other respiratory viruses this fall and winter, and vaccination may decrease the burden on the healthcare system by reducing the risk of infection and co-infection in individuals, and reducing the occurrence of outbreaks in high-risk settings such as long-term care homes. I will now talk about antiviral medications that are available for influenza and COVID-19, and of note, there are no antiviral medications available for RSV. Neuraminidase inhibitors are the main class of antiviral medications for influenza and work by blocking the exit of the virus from respiratory cells and prevent further replication of the virus. They're used for treatment of individuals with moderate or severe illness or those at risk for complications of influenza. They're also used for treatment of prophylaxis in outbreaks. Influenza antiviral medications work best if administered within 48 hours of symptom onset, but should be used beyond that time period in severely ill individuals or those at high risk of complications. Treatment with antiviral medications decreases the duration of influenza symptoms and can help to prevent the complications of influenza, such as hospitalizations and potentially deaths. Main antiviral medications for use in Canada for influenza are oseltamivir and zanamivir. Oseltamivir, or Tamiflu, is an oral medication, can be used for treatment of influenza in individuals 1 year of age or older, and can be used as prophylaxis in outbreak settings. Zanamivir is an inhaled medication that can be used in individuals 7 years of age and older. And an analysis during the 2022-23 influenza season. Of all 599 influenza viruses that were tested by the National Microbiology Laboratory, all were sensitive to both oseltamivir and zanamivir, and this included influenza A H3N2, influenza A H1N1, and influenza B viruses. Influenza antiviral medications are recommended for treatment if the following three criteria are met. If influenza is circulating in the community, if a patient has symptoms compatible with influenza, and if a patient is at high risk for complications of influenza, or if a patient has moderate, progressive, severe, or complicated influenza, such as individuals who are hospitalized with influenza. And to answer that first question about whether or not influenza is circulating in your community, I encourage you to take a look at the Ontario respiratory virus tool that Mike was discussing earlier. Regarding whether your patient has symptoms compatible with influenza, it is difficult to distinguish influenza, COVID-19, and other respiratory viruses, including RSV, based on clinical symptoms alone, especially when there are multiple respiratory viruses co-circulating in a community. Public Health Ontario has published a document that will be updated shortly that highlights the key features of influenza, SARS-CoV-2, RSV, and rhinovirus. But the symptoms of these respiratory viruses are quite similar and do overlap, so it is not possible to make a reliable diagnosis based solely on symptom presentation. And regarding whether a patient is at high risk complication of influenza, according to the Canadian Immunization Guide, individuals who are at high risk for complications include residents of nursing homes or other chronic care facilities, adults 65 years of age and older, persons with underlying medical conditions, pregnant people and individuals up to 4 weeks postpartum, Indigenous peoples, and children under 5 years of age. For COVID-19, antiviral treatments can prevent serious illness if taken quickly after symptoms start. However, unlike influenza antivirals, COVID-19 antivirals are not used on a prophylactic basis in outbreak settings. COVID-19 antivirals are recommended for individuals who may be at high risk for serious illness, including individuals 60 years of age and older, individuals 18 years of age and older who are immunocompromised, and individuals 18 to 59 years of age with underlying medical conditions. Available antivirals include Paxlovid and remdesivir, with Evusheld no longer routinely recommended, which is likely ineffective against currently circulating variants. I'll now hand things over to Dr. Hassa, who will be talking about testing.
Yeah, thanks, Richard. So for respiratory virus testing availability during the season. So PHO facilitate testing for respiratory viruses, and this will support like early clinical intervention to aids in treatment decision-making and also infection prevention and control measures. Same time, it's also will provide information for public health response strategies. And lastly is the benefits of surveillance purposes, including trends over time, viral strains, geographical distribution, and vaccine efficacy. So the availability of testing at PHOL will be SARS-CoV-2 PCR. There's also the Fluvid, which covers like 3 viruses, the influenza A and B, SARS-CoV-2, and respiratory syncytial virus. MRVP, which is the multiplex respiratory viral panel, will cover a larger panel of respiratory viruses, including influenza A and B. At the same time, it will provide subtyping for flu A, which will cover both the H3N2 subtype and the H1N1, the pandemic strain. Apart from that, it will also provide results including parainfluenza, enterorhinoviruses, adenovirus, RSV, and seasonal coronaviruses, and metapneumovirus. For outbreak testing at PHOL, so going through the data from the last season, which is the 2022-2023, PHOL did provide investigation for outbreaks for 3,641, and out of those, 46% were positive for at least one seasonal respiratory virus. The highest number came with enterorhinovirus at 18%, followed by RSV with 10.7%, and then with seasonal coronavirus with 8.1%. For influenza outbreak investigations, influenza A came with 6.8% of the total outbreak investigated, and influenza B with a small number with only 0.5%. For COVID-19 outbreak investigations, there were a large number included in the testing, which covers 4,052 outbreaks, and out of those, 62.8% did test positive for SARS-CoV-2. For information about SARS-CoV-2 testing, you can visit the test information sheet at the Public Health Ontario website to look into any updates. There was a recent update beginning of this year in February, which covers specimen types, including a combined oropharyngeal and nasals, also the saliva representation, which lumped the neat collection versus the mouth rinse and the swish and gargle. Also, there's a table which can provide expected performance ranges by specimen types. Going into the testing eligibility, so for the multiplex, which is the MRVP, this will cover symptomatic hospitalized patients, both ICU and wards. Also symptomatic children under the age of 18 years visiting emerge department, and this will serve mainly for the purpose of surveillance. The third eligibility will be symptomatic residents in institutional settings, non-outbreak. And then the last one is the samples from the first 4 symptomatic individuals, including healthcare workers and staff in an outbreak setting. For Fluvid, which covers the 3 viruses as we discussed, the flu, AB, RSV, and SARS-CoV-2, it goes with the symptomatic residents and healthcare workers and staff in an institutional setting in an outbreak situation that requests COVID-19 and respiratory syncytial virus and influenza, and this will cover beyond the first 4, which are eligible for the MRVP testing. As we can go more in depth into the outbreak, as we discussed earlier, the first 4 will go into the MRVP testing. Once there are some data that shows that 4 samples is enough to provide, once you get the etiological agent for that specific virus, it will be sufficient. You can stop testing. However, PHOL can support further testing if this will support management of the outbreak. So any specimens beyond the 4 samples can go into Fluvid testing, which will provide information about the 3 major viruses. Rapid influenza testing is also available, specifically when molecular testing cannot be performed in certain regional sites where due to remote settings. So rapid flu testing can be performed in these settings, and then the sample can be referred back to other regional labs within PHOL to perform the rest of the MRV panel. Testing for asymptomatic individuals within a COVID-19 outbreak setting is eligible in certain indication according to the public health setting, and the sample will not be testing further for any other respiratory virus. So it will cover only the SARS-CoV-2. To assure that the test is well ordered, follow the guidance and use the COVID-19 and respiratory virus test requisition to provide all the informations. Assure that if it is an outbreak settings, provide the outbreak or investigational number. We know that nasopharyngeal swabs are the most sensitive. However, saliva is accepted for SARS-CoV-2, but for the rest of the respiratory vials, it's not validated. As we discussed earlier, asymptomatic testing is only covered for SARS-CoV-2. So if there are no indications for symptoms, the requisition requested MRVP, the test will be rejected. And to assure a good turnaround time and there will be no delay or rejection of the specimens, make sure that the collection kits are well checked regarding their expiry dates. Ontario Health links, which is provided here in this slide, can provide an expansion of the expiry date of certain collection media. So you can go through these media and check before collection of the specimens. Make sure also to provide 2 patient identifiers and label the specimens correctly together with the collection tube to assure that the sample will not be delayed or rejected. The turnaround time and frequency. So for rapid flu testing, the result will be available within 24 hours, as we discussed. If the molecular assay will delay beyond that time, so it will go into rapid flu testing. And for fluvid testing, the result will be available within 24 to 48 hours. Some of the MRVP testing will delay, as we discussed, for example, for like emerge patients for pediatric populations. It's mainly used for surveillance purposes. So it might delay beyond up to the 4 days of the recipient at the PHOL. PHOL also is can provide any further support if there are any extra testing that needs to be requested. So you might use the general test requisition. There's an updated version within the website. You can look into that new version for any other extra testing. You can communicate with the customer service, and the number is provided in this slide. We don't forget also the PHOL is provide testing for other respiratory virus, including avian influenza, and can do also subtyping for surveillance purposes. So if there's like any exposures to poultry or like infected mammals, so please provide this information within the requisition and you can request avian influenza testing. Antiviral resistance for influenza is also can be provided apart from MERS-CoV-2, MERS-CoV testing, and enterovirus D68. For the genomic sequencing, PHOL is still providing the weekly whole genome sequencing report on a weekly basis, the same like the previous season. A new report will be provided for both RSV and influenza. So there will be an expansion of the genomic program beyond the SARS-CoV-2. This will be used for surveillance purposes to provide the strains circulating in the province and any antiviral resistance and vaccine match. This will be not on a weekly basis. For influenza, it's going to be just like 3 reports, early, mid, and late of the season. And for RSV, it's going to be only like a single snapshot report. And just lastly, we'll provide acknowledgements to public health units, Ministry of Health, and both arms of PHOL, both health protection and the laboratory. And I can hand it back to Andrea. Thank you.
Thank you, Mon and Michael and Richard as well for your excellent presentations. As we now move into the discussion period, please remember to keep entering your questions into the Q&A pod if you haven't already done so. Your participation in the discussion period is greatly appreciated. It is now my pleasure to also welcome Dr. Sarah Wilson to our discussion panel. Dr. Wilson is a public health physician with the Immunization and Vaccine Preventable Disease team at Public Health Ontario, and is also a member of Canada's National Advisory Committee on Immunization, known as NACI. Please welcome Sarah, and thank you for joining us today. So we've had a number of questions already pop up in the chat, which is great. So I will get started. This first question is from Michael. You mentioned in your discussion about respiratory virus activity in the Southern Hemisphere that Australia observed a much lower incidence of influenza in the 2023 season compared to 2022. And there's a question about whether or not this may have been related to increases in influenza immunization rates. And do you have any information on whether or not that might be the case?
So I was able to find from the National Center for Immunization Research and Surveillance in Australia some information on vaccination coverage for flu. And I can put the link to that in the chat, but it looks as though vaccine coverage was lower in the 2023 compared to 2022 in Australia across age groups.
Okay, great. Thank you for pulling up that information for us. This next question would be for Richard. You mentioned that the high dose influenza vaccine, the one that contains 4 times the amount of antigen, is available currently under the UIIP for those 65 years of age and older. There's a question about whether or not this high dose vaccine would be recommended for individuals under 65 who are immune compromised, and if not, what is the rationale for not permitting that vaccine option?
That is a good question. So the high dose vaccine is only authorized for those 65 years of age and older. I'm not sure if Sarah has any more insight into the specific reasons for those NACI recommendations.
I can build on what you've said. I mean, I think NACI's recommendations for influenza vaccines currently are aligned with authorized indications. So I think that's an important influence in terms of why they're recommended for those 65 plus and not an off-label recommendation at this time.
Okay, thank you, Richard and Sarah. This next question is for Mon. The question is regarding whether or not there is a separate swab for the MRVP test, or are individuals using the current ones and checking off the requisition accordingly?
Yeah, thank you. So if you go to that our test information sheet within the lab, you can have like the information provided. You can use the same swab, which is eligible for that cover both MRVP and like including like all the viruses, so they can use that swab. There is within the COVID testing, there's like a list of like all the collection kits and their eligibility criteria for specific assays, including the Fluvid or separately for COVID or like the MRVP. So all the information are available with the good pictures also.
Okay, great, thank you. This next question is for Richard. The question is, for a high-risk elderly patient in the community, what should be the appropriate timing of the RSV, flu, and COVID-19 vaccines? Should the RSV vaccine be given first and then wait a few weeks for the Fluvid and COVID doses? Or is there another recommended sequence of vaccines for that population?
So I'd say there's no specific recommendation for that, and it would be based on what is circulating in the community and what vaccines are available. So if you look at the current epidemiology right now, there's increasing rates of COVID-19 circulating in Ontario and low rates of RSV and influenza. So that would make me prioritize COVID-19 vaccination over vaccination for influenza and RSV. And also the vaccine availability. The newer COVID-19 XBB 1.5 vaccines are becoming available currently and are going through distributions of the next few weeks. And influenza vaccine distribution will start shortly. But I haven't heard any timelines yet on when the RSV vaccine will be distributed. So as it's not currently being rolled out, I think I prioritize the COVID-19 vaccine and the influenza vaccine that are currently available right now. But for each person, I'd recommend having sort of an individual level discussion with their physician about what would be the best recommendation for that person.
Okay, thank you, Richard. This next question is for Mon. There's a question about what testing options might be available for community clinics, excluding hospital and or outbreak scenarios.
Yeah, that's a great question. So PHOL do participate in Sentinel Practitioner Network which mainly provide information regarding vaccine efficacy for influenza, and it is going beyond that to COVID also. So there are certain practitioners who participate in this program, and you can communicate with the lab and with the incidence and outbreak response team to provide you more information about that for eligibility for that participation. And this is like a national program which involved other provinces, including British Columbia, Alberta. So otherwise, currently till the guidance now, there's no testing eligibility for outbreak settings.
Okay.
And this is the Sentinel program is mainly for surveillance purposes. It's used. So they are eligible for MRVP testing.
Okay, thank you. This next question is for Richard. There's a question regarding, you mentioned some of the risk factors or populations that might be at an increased risk of complications from influenza. And there's a question asking, why are Indigenous peoples in particular considered to be at higher risk for complications?
That's a great question. My understanding is that there's no a single one risk factor that would explain why Indigenous people would be considered a higher risk group for complications from influenza. There is an article from the National Collaborating Centre for Aboriginal Health, which is funded from the Public Health Agency of Canada, that does discuss some potential determinants of the prevalence and severity of influenza infection in Indigenous populations in Canada. Some of the factors that article discusses is geographic factors, including the isolation of communities and access to healthcare services, demographic factors, socioeconomic disparities, cultural factors, health status, health behaviors, and potentially genetic susceptibility. So I can share that article in the chat for more information, but no one single factor. Sarah, do you have anything else you would add to that?
Sorry, did you say, I think I missed my name, but did you say something?
Sorry.
Yeah.
Sarah, no, I was just asking if you had anything else you would add to that based on your work with NACI for why that would Indigenous people were selected as a high risk group.
Yeah, I think it's definitely complex and multifactorial, and I think there are some structural issues in terms of structural barriers, discrimination, and longstanding issues that also contribute to what's being observed, and that's not just for influenza, but for a range of different outcomes, including COVID-19.
Okay, thank you. We had a question about whether or not PHO had data available on the number of outbreaks in long-term care homes or retirement homes. And I would just like to point people in the direction of the Ontario Respiratory Virus tool that Mike mentioned earlier in the presentation. That's available if you go to the PHO website and search for the Ontario Respiratory Virus tool. And there are components for all three viruses that can tell you what the proportion of reported outbreaks in long-term cares and retirement homes or institutions, public institutions, by pathogen. So Mike has provided the link in the to everyone, and you can find that information there. So this next question is a bit of a two-part question from Richard. It's around antivirals, and you mentioned that an influenza test is not required prior to administering influenza antivirals, but should clinicians or patients be performing a COVID rapid antigen test before starting antiviral therapy to be able to identify which virus you're actually treating? And the second part to that is, are there any risks to, for example, administering influenza antivirals if the patient actually has COVID or RSV, if you're treating them for the not the correct virus?
Okay, thanks. So regarding using a rapid test for one virus to confirm what virus you have, there is a possibility that someone could be co-infected with two viruses. So if you have if you have respiratory symptoms and you have a negative COVID rapid test, that doesn't necessarily mean you have influenza. You could have another respiratory virus. And conversely, if you have a positive COVID-19 rapid test, then that doesn't rule out the possibility of having influenza. So the recommendations from the Academy of Medical Microbiology, Academy of Medical Microbiologists of Canada is that influenza antivirals are recommended if influenza is circulating in the community, if someone is at high risk for complications, and it doesn't factor into specific testing for COVID-19. And sorry, the second part of that question, can you just repeat that?
Whether or not there are any potential risks in administering an antiviral if it's not the correct virus, if you're not targeting the right virus without doing any testing.
I'm not sure if Mon could better speak to that, but I'm not aware of any specific risks. It would not be effective if you administered antivirals for the wrong virus, and for any medication, there are the potential for adverse effects from that medication. So it would always be best to ensure you're using the right medication for the right person. But Mon, I don't know if you have any other.
No, I completely agree with you, Richard. It's not going to be like a harm unless there are certain like contraindications specifically to that patient, which can communicate with the PHO to provide like more support with that. If there are certain contraindications that you cannot use that specific medication to target a specific virus, but generally there are none.
Okay, thank you. This next question is for Mon. It's regarding long-term care homes that have their own in-house testing capacity for COVID, flu, and RSV. And specifically, is it okay to send a swab to Public Health Ontario labs for multiplex testing after a symptomatic resident tests negative for COVID, flu, and RSV?
Yeah, it's like, I'm just want to confirm, is it like part of like an outbreak setting, or it's just like a symptomatic individual?
I don't have any additional context for
It's
that
not provided.
question.
Yeah.
No.
Yeah, if it is part of an outbreak, usually as we discussed like earlier, like we can test like up to 4. And if it was identified the etiological agent, it will stop at that stage. But there are certain scenarios where you can communicate with the lab, and this is under the discretion of like the health unit, or like you can communicate also with the microbiologist at the lab. Will be permissive for testing fluid, because if the management will be changed, if like a new etiology will be identified. For example, you have like a combined virus infection, like an entero and a COVID. So will be permissive in providing like these assays. So you can just communicate with the lab and provide your inquiry, and the lab will be happy to support you.
Okay, thank you. This question is for Richard again, regarding COVID vaccines and the sort of recommendation that the vaccine be given 6 months after the last dose has been administered, and whether or not in long-term care homes for healthcare workers and residents of long-term care, if that 6-month recommendation is a hard recommendation, or if individuals can receive a new vaccine if it's been, say, 3 to 6 months from the time they had their last dose.
Thanks. So the 6-month interval is recommended as the optimal interval for the immune response to the vaccine. In the NACI guidance, it does note that shorter intervals between 3 and 6 months may be considered. So there could be circumstances where a shorter interval is used, but that a longer interval does have a better immune response. Sarah, anything else you'd want to add to that?
I think you've summarized it well, but I think it is really important to underscore that that 3 month is considered a minimum interval and can be used. I think the NACI language is clear that that interval can be used to support program implementation. I think there's a lot of feasibility aspects in terms of mounting influenza and COVID, and then we've recently learned also RSV vaccine programs. So I think the 3 month interval, there is certainly language in the NACI guidance indicating that that's acceptable, it's permissible, and I believe the ministry guidance also endorses that as a minimum interval, and could be very helpful in terms of program implementation this fall.
Great, thank you so much. A question for Richard again about oseltamivir and whether or not, how do individuals access antivirals for influenza? Are they available directly from a pharmacist, or do they need to get a prescription from a physician?
Currently, a prescription from a physician is required. My understanding is that the ministry is considering having pharmacists be able to prescribe it for this fall. There have been some media reports about that, but I haven't seen any official decisions made on that yet. But it may be happening this fall.
Okay, thank you. A question from Mon regarding lab testing. Where can individuals go to request to order PCR testing kits and rapid antigen testing kits?
Yeah, so for rapid antigen testing kits, you can communicate with Ontario Health and see what's the guidance for the supply, and you can communicate with the lab to for the kit collections and to support you with that order, but not for the rapid test. Ontario Health will be the best place to reach out.
Okay, thank you. And thank you, everyone. And unfortunately, that's all the time we have for questions today. As we wrap up today's PHO rounds, I would like to give a warm thanks to Michael Whalen, Dr. Richard Mather, and Dr. Mon Hasso for their presentation, as well as Dr. Sarah Wilson for joining us for the Q&A and providing her knowledgeable input. I'd also like to thank everyone who joined us for today's PHO webinar. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our future programming. And a reminder to everyone to save the date for the Ontario Public Health Convention, also known as TOPIC, which will be held between March 26th and April 3rd in 2024, and is now accepting abstract submissions for the program. So please check out topic.ca for more details. And finally, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you, everyone, and have a wonderful rest of your day.